everyone to the first ever Health Storm Live. I have Robert Longyear here with me. Robert, thanks for doing this. I'm excited about it.
Yeah, me too, Vic. Glad to be here.
So we have everyone just coming in to the Health Storm Live right now. But as usual, I've done webinars and I've done Health Storms both separately. This is the first time we're sort of mashing them together into a deep dive, really around technology in healthcare, telemedicine, telehealth, how the infrastructure is evolving through the pandemic. And I'm just going to give a couple quick kind of housekeeping items. I'll introduce Robert in a second, but Robert and I will go through probably half an hour, maybe 40 minutes of just discussion about this topic. But then we're going to have plenty of time at the end for questions with exactly what you want to discuss, what you're interested in. And so please go ahead and use the either the chat or the QA button down at the bottom of the Zoom panel to type in what you're interested in. I'll try to weave them into the discussion as I see an opportunity, if it fits with what we're saying at the time. Or alternatively, we'll come to them at the end and try to make sure we catch as many questions as we can. So feel free to do that anytime. You don't have to wait until the end for it. And so with that, I've known Robert for a while. He and I did a Health Storm probably 6-8 months ago. Robert, maybe give you a quick background of you have an incredible story for where you are in your career. Talk about your background just a little bit.
Right. So I studied healthcare management policy at Georgetown. That's really where all this started. I wanted to go to medical school for the longest time, but I learned very quickly that things are changing very fast in healthcare. And I got very interested in the areas that were a bigger opportunity to improve health for people primarily with chronic conditions. So I started working on the payer side of healthcare, understanding how reimbursement and the incentives work from a health insurer or managed care perspective. And then I ended up doing research at the Institute for Medicaid Innovation on high-risk care coordination and information systems in Medicaid in particular. For those that don't know about Medicaid, Medicaid is the safety net healthcare coverage program in the country. It covers people of low income, and it's where we have a lot of very, very sick people. And so the goals of the program are to develop new models of care that more effectively help manage that care for these individuals, as well as preventing, high cost episodes. So that research took me to working with a large number of managed care organizations and large health insurance companies to source best practices. That's when I started getting very interested in digital health, virtual care, because some of the themes that emerged from that research were that this is the future. My passion for this space really drives from my experience as a leukemia caregiver for about 8 years. So I've seen the whole spectrum of very, very sick patients from, diagnosis all the way through palliative care. So I was a caregiver for my mom. I lost her when I was 20. And our experience as caregivers in navigating multiple different healthcare providers and sites of care really kind of taught me that the future of health is virtual, it is telemedicine, and it's better for the patient, and it has an opportunity to also improve outcomes outside of just improving experience and access to care. So that's my background in short.
Yeah, I mean, one of the things that I think is great about your background is you have that dual experience where you certainly have spent a lot of time in industry and with providers and even in research around providers and payers. But then you also have experienced it, firsthand through the whole process of diagnosis, through treatment, all the way, unfortunately, to your mom's passing. So that perspective, that sort of dual perspective, I think, really brings a lot to the analysis of things. So, so as we talked about in the promotions for this, the thesis is that COVID, the health crisis of COVID, has really forced, due to patient safety, has forced the industry to really look at technology that has been in place for a long time, but that was never really utilized because people providers and even patients to some extent don't want to change behavior. It's hard to change behavior. COVID, for patient safety reasons, really forced a very fast analysis of how do we treat patients when it's not safe to come into the hospital. And in a matter of 2, 3, 4 weeks, state and federal guidelines in both regulatory guidelines and reimbursement guidelines were completely written to enable this to happen because of public health concerns. And it's been a really interesting sort of live experiment to watch. And I wanted Robert and I to sort of just talk through, the early returns from that experiment. What have we seen evolving? And then a little bit about where do we see it going from here. And so, Robert, but I want you to talk about your research into virtual care models. I know you've been researching this for an upcoming book and done a lot of work into like, how is care kind of best delivered virtually? How's it done today and where's it headed?
Right. So, yeah, Vic, I mean, COVID-19 has changed a lot of things for everybody. And so I wrote my first book last year. It was published in April 2020, and it covered a lot of broad topics in healthcare innovation. It's called Innovating for Wellness. And the idea was to cover sort of the intersection between value-based payment and digital health technologies that kind of allow us to change the way that care meets the patient. And so out of that book, I happened to get another book offer for a deal with Routledge, Taylor, and Francis in April. I didn't really want to write another book, but the opportunity kind of fell in my lap. And during COVID, it was in the middle of that. I thought I'd have more time. That hasn't necessarily been the case. But I took the opportunity, and that book is nearing completion. And what I wanted to do in this book is really dig into virtual care. It's a topic that's going to be important going forward. And I wanted to write something that could be interesting and dynamic, but also educational for what do we know about this space right now? How has COVID changed that? And what do we know about virtual care models and telemedicine with respect to patient outcomes, with respect to patient understanding and experience, and with respect to cost? And so I wrote this book for health systems and physicians and healthcare providers that are looking to incorporate this into their practice. So what have we seen? COVID-19 really dropped the amount of in-person, face-to-face visit volumes that were possible for patients across the spectrum. Back in April and March, there was a lockdown, so people actually weren't allowed to be open. Elective procedures or non-emergency procedures really dropped in terms of volume. And facilities had to turn to something to provide care to their patients. And so a lot of times what we saw was them turning to telemedicine to be able to offer these services. Now, telemedicine is a broad term, and so is telehealth, so is virtual care, so is remote patient monitoring. And so all of these terms often talk about the same type of model or different types of models. But what we really saw was an expansion and a replacement of what could have been done face-to-face in April and March into a virtual visit with a patient. And the primary driver of that was behavioral health services. The primary driver was anything that has to do with mental health that can be delivered via audiovisual telemedicine. And the reason why this was able to be done is the policymakers and Centers for Medicare and Medicaid Services allowed for practice across state lines for clinicians. So that really opened up the floodgates for telemedicine companies to be able to offer services across the country. And then payment parity was also important. So historically, the reason why telemedicine may not have had as much uptake has been that it's reimbursed at a lower rate than a face-to-face visit. And so when payment parity was reached, it became possible for practices and healthcare organizations to offer these services to patients at the same rate as an in-person service. So I think that's a good overview.
It makes sense to me. Like the technology capacity was in place for years, right? But the regulatory environment was not conducive to it. You couldn't work across every state line. I mean, a few areas of the country you could, but there wasn't sort of easy flexibility across state lines for your medical license.
Right.
And then separately, docs didn't get paid. Health systems didn't get paid the same level, or sometimes didn't get paid at all, depending on the specialty and what the procedure was.
Right.
And really, due to the public health need, the federal government and working with state governments fixed both of those impediments. So very quickly, they removed these, what I'd call barriers to adoption.
Right.
And I think what we saw is that in some specialties, I think behavioral health is probably the leading one, but there's others. Physicians like it and patients like it, and it is pretty effective to do some level of care over virtual settings, just like we
Right.
are now. I mean, we're not face to face now, and certainly I can understand what you're talking about.
Right. And so, Vic, I think it's really important to recognize where we came from here. So telemedicine has been around for a really long time, early 2000s, even before that, but it really took off kind of the early 2000s. One of our medical advisors here at Wanderley Avenue, Dr. Richard Boxer, is one of the founding chief medical officers of Teladoc. And I interviewed him for my book to talk about sort of the early days of telemedicine. First of all, it was a struggle to get state boards to accept that this is a reasonable way to deliver care to patients. So that was a big hurdle. They got over that, which was, in part due to Dr. Boxer's work. And eventually
for Teladoc, partly just due to like massive manpower and attention and pushing through all the different states.
Yeah. Yeah, and the truth is that the core of audiovisual telemedicine, which is what we're basically doing right now, there's a limited scope of practice there, which everybody's known. So you can't often take care of chronic illnesses like that unless you're doing kind of follow-up care. It's a little bit harder to take care of patients that are having something you need to touch them with.
Yeah,
so
you're not going to put a stent in.
Yeah. Yeah, so the scope of practice issue really plagued audiovisual telemedicine for a really long time, and that it was really just like sinus infections and writing prescriptions and things like that for people who just wanted to get a convenient, care very quickly. But what it really did in the early benefit of this modality of care is access, increasing access for people. So people in geographic areas without primary care physicians, without some sort of specialist, that's where you're able to give them access to this type of consultation when they can't physically go to a brick and mortar location within a reasonable distance to their house. And that's where this whole thing started. It's like, oh, we can give people healthcare services that can't access them. And that's still one of the core benefits of telemedicine today. And during COVID, it's not safe for people to come into the clinic. They can get infected. And so it was giving people access, even if they do have a close proximity healthcare provider, but now it was unsafe.
Yeah, right. Yeah, so we've got a couple questions coming in. And I want you to address one. So one of them is a physician I think he's in California, but he said that some of these opportunities are being rolled back now, and I think that's true based on the reimbursement code or the procedure. Like, so for different specialties, they're being rolled back. For other ones, they're not being rolled back.
Yeah,
there's been on the specialty.
There's been an expansion of these services from CMS in a number of different conditions like cardiac rehab and things like that, there's been an expansion. I think we're all waiting to see what happens post-COVID for reimbursement and for this medical licensure stuff. It doesn't make a lot of sense to have physicians unable to practice across the country. But the reason they do it is because state medical boards make money off of the restrictions in licensure. So it's one of those just regulatory things that really inhibits providing good care to patients, and it's done for financial reasons. And at the end of the day, that doesn't help us very much.
Yeah, I mean, that's one of my pet peeves, as a venture capitalist, free market kind of guy. Local kind of groups protecting their embedded monopoly on handing out a piece of paper saying you can practice in this state is ridiculous. And we with the internet and where we are in 2020, almost 2021, we need to move on beyond that. And particularly if you can't, I'll just take behavioral medicine as the most obvious example. But if you can't find a doc in your state, which a lot of states, almost maybe all 50 states, there's a shortage of behavioral medicine providers.
100%.
You have to be able to try to go elsewhere. It's all, I think it's even ex-COVID, it's a patient safety, patient reliability, getting care to the right people.
It is. And behavioral health workforce in the United States is much smaller compared to other countries. And there are a lot of even within states and geographic regions where they can't refer, like a PCP cannot refer to a psychiatrist because there's no one there. And so it really is an access and an overall quality of care for the rest of the country issue that needs to be addressed. And that was one of the big things that drove a lot of the adoption during 2020, during COVID-19. And the other thing to keep in mind, though, is that there's a cultural aspect to this, and patients and physicians and healthcare providers have to adopt this modality and work it into their workflows and culturally accept it. And so even though in April and March, we did see a large uptake and exposure to this type of care, and we do expect that to continue going forward, things did kind of level off when things opened up again. So there's still a push to both due to reimbursement pressures and just cultural elements to continue to meaningfully incorporate these models into existing clinical practice.
Yeah, and I think there's going to be sort of maybe 2 or 3 things that happen over the next couple of years as we, hopefully begin to get the vaccine and begin moving beyond the crisis of COVID and more in the ongoing kind of post-COVID world.
Right.
I see sort of 2 or 3 things going on simultaneously. One, I mean, you're a big proponent of this. There can be more data collection, and we could strengthen what we mean by virtual care. It may not be only audio visual. You could have some data collection. You might have ongoing interactions, collecting data either passively or actively from me that then the physician might review with me over time.
Right.
And then that could augment the treatment. I think you will have some that return to in person because now it's safe to, and you certainly can get a better experience. And there are things that docs can do by feeling the body, interacting with the patient that you can't do virtually.
Right. So let's talk about the issue that really is at hand in healthcare. This is what my book's about. It's chronic disease. It's hypertension, heart diseases, diabetes, some cancers. These are the things that cost us a whole bunch of money in the United States and that patients end up going to the hospital for at the end of the day. And telemedicine, audiovisual telemedicine has a limited scope of practice that's reasonable. And you really do need to make sure you have a continuous relationship with a primary care physician, which if you call Teladoc, you might get randomized to another clinician. So getting your hypertension treatment and your true primary care from there doesn't make a whole lot of sense. You need that continuity. Yeah. And where I think this industry is going and why I refer to a lot of the technologies in the care models as virtual care rather than telemedicine is because we're starting to see an emphasis on chronic care. And this model is going to become very much incorporating remote patient monitoring. It's going to incorporate audio visual. And so we're going to be able to have sort of full service clinics that are done virtually. And what's important from that is the access and the convenience, which is not just a market-based benefit or competitive element. It's patients need to be able to devote more time to their health to be able to manage it. They need to devote behavior change time. They need to understand their metrics. And so the average clinician visit face-to-face in this country is about 21.6 minutes each time. And when you're talking about chronic disease, there's a lot of components that go into how the outcomes progress. You have behavioral and lifestyle components, how patients eat, how they exercise, what they do for a living, do they smoke? You have the actual physiology itself, which is often treated by a medication or some other type of treatment. And then you have socioeconomic factors that require addressing. So between those 3 categories, a 21.6 minute visit is perfect enough to talk to the patient, review with them, and write them a prescription, tell them to exercise and send them home. But the model of primary care that's effective is high touch primary care that's spending more time with patients and that's trying to implement behavior change and trying to address and understand their socioeconomic pressures so as to refer them to social services. And what you get from virtual care programs in this type of model is if you have a patient with a smartphone, your visit can extend throughout the month. It can extend throughout the year because there's a constant stream of either communication or data collection from that patient. So hybrid virtual care models going forward that incorporate remote patient monitoring, that incorporate patient education delivered through the phone, and that incorporate audiovisual technologies is going to be the future. And so patients can now have this experience in their living room. They can do it every week as opposed to every 3 months as is current. And it's something that's going to drive better clinical outcomes by building these experiences around the patient and extending the scope of practice from a sinus infection to to hypertension, to diabetes, and to these diseases that contribute to a lot of the cost and suffering in the country.
We may be able to co-opt models from other parts of our world, right? So maybe if I'm trying to learn a language, going to a 30-minute class once a year is not the best way to sort of change my behavior and learn to speak Spanish. It'd be much more effective to do a little bit every day. And same if I'm trying to change my exercise habits, my eating habits, any of health habits, getting a professional advisor, whether it's a physician or a physician assistant or a health coach, or a mix of those, to interact with me many times over the year, and then have an app or an automated tool that I could interact with daily or even more often than daily, is much more supportive in me kind of sticking to that and overcoming hurdles and kind of relearning how to live my life or how to approach things.
Absolutely. And at the end of the day, these connected care models and this relationship-based care is where things are going to go. And the technology is a facilitator of that. It's not like a new anything. It inserts itself into clinical best practices now to give patients more of a connection to their health and to their care team. So what it allows you to do is collect that data in real time to be proactively pursuing health, which is good for monitoring, but it's also good for patients to have their own ability to look at their health metrics and say, hey, like I am progressing well, my blood pressure is coming under control. I have the self-efficacy to manage my own condition, which has not happened in healthcare for forever. It's always been the domain of the physician to have this paternalistic relationship with the patient and say, I have your health data. I will tell you how you're doing, rather than empowering patients to have their own data. So that's the effect of doing that. But you also, when it comes to scaling these types of programs, that's always been a barrier. It's hard to scale. It's hard to make this actually a reality because of cost pressures. But when you are able to route a patient who needs care to the appropriate level of care, maybe it's a health coach, maybe it's a diabetes educator, maybe it's a nurse, maybe it's a pharmacist, maybe it's a physician if it's a big problem.
Here, that's no cost at all. I mean, there's probably different levels for different purposes.
Yeah. So, and that's where the beauty of these programs come in when it comes to a cost perspective. So it's not just getting on with your physician and then being reimbursed for their professional time. It's let's build a full program and let's have different levels of care. Maybe a patient just needs to ask about, can I eat this particular meal, or is this healthy for me? How can I reduce sodium in my diet? Physician doesn't need to be answering those questions. Physicians need to be managing the overall health of the patient. They need to be there for big clinical developments. They need to be the quarterback. And there's other team members that can take the loads off the physicians and that can provide enough time for that patient to encourage behavior change and to collect and understand that patient so as to address socioeconomic things like food insecurity, housing instability. Those are the types of things that you can get from more robust programs that aren't centered around patients coming into a physical location, writing a prescription, and sending them home.
Yeah, excellent. So I want to dig into the experience. So how has the experience been as we're trying to navigate through COVID using telehealth and telemedicine and virtual care models? Sort of at three different levels. How have the patient liked it? How has the provider liked it? And what about the payer? Do we have any early data on those different constituencies and how they're receiving it, or how are they experiencing the use case? I really like it.
Yes, so I'll start with patients.
Okay.
When we're talking about telemedicine generally, and typically this is audiovisual, patients have reported a higher satisfaction score than in-person care. So it's marginal, it's about 4%. I think it's a difference between 90% satisfaction and 94% satisfaction for telemedicine. But imagine not having to drive to the clinic, not having to wait in the waiting room, and being in the comfort of your own home. I think that contributes to that main 4% there. So we know that patients like it. When you look at RPM programs outside of just telemedicine as a category, what you see is patients feel like they understand their condition better, they understand their health better, and they have better self-efficacy for actually caring for themselves. And so patients really do enjoy these types of models because it's a new experience from healthcare. I mean, if you walk into a clinic, you're going to get a piece of paper and get sent home and say, take care of yourself. And at the end of the day, that's not what patients need, because health is complicated and it's confusing and it's not taught very well in our schools. So there's a little bit of extra pushing and nudging and support that's needed to really, improve care for patients over time. Providers, it's a mixed bag, to be honest with you. I think what we've seen is a lot of people. I just surveyed a bunch of our nurses at Wanderly, and a lot of them really do enjoy doing virtual care. So they like to work from home. A lot of clinicians have never had the opportunity to work from home. So I'm seeing some interest from clinicians at having a hybrid schedule. Maybe they'll do follow-ups on Friday and they'll work from home and do them virtually. I think it really is sort of a mixed thing for people based on preference. And physicians overall
How
have
they
become
organize it themselves. I mean, maybe it's their preference, maybe how their clinic or how their system has like allowed them flexibility or hasn't allowed them flexibility.
Yeah. And if you do incorporate other clinicians and other care team members to do a lot of this stuff, physicians can actually kind of remove themselves from like this paperwork and crazy burden, and they can really try and get back to what they want to do, which is practicing medicine and helping to manage patients. The EMR has really burned a lot of clinicians. It's caused a lot of burnout, and that's a little bit of a barrier to getting adoption at a widespread scale from clinicians, because they're like, look, you told me this EMR was going to make my life easier, and it's made me miserable and want to leave medicine. And so they are hesitant for us to say, look at this new technology, you're going to love it. And so it's the workflow component is essential. Making sure that the documentation, everything is easy and works really nicely is really important to ensuring adoption. The health systems and the business case really only cares as long as they can, keep the revenue coming in and that it's a sustainable program. The true best case scenario for virtual care and some of these models I've talked about is full risk models. So organizations like ChenMed and Iora and Aledade getting into taking more risk where they have the cash flow available and they're not kind of bogged down by the billing system. Well, it really allows them to build these meaningful ways of engaging with patients without worrying about reimbursement. But for fee-for-service providers, it's another story. It's still driven, mostly adoption is driven by that payment. And it will always be that way until things move to more full risk. But for competitive reasons, the facilities themselves are seeing a need to implement this because patients are starting to like it. And they're like, oh, I would rather do this than, drive in traffic to my clinic.
Right. And then what about the payer community? CMS and other commercial players, maybe Medicare Advantage. Do you have any data on are they seeing a benefit? And then that might go to, will these reimbursement levels, parity reimbursement, might that be maintained, or is it going to be subject to attack?
Yeah, so I think CMS is going to keep most of the stuff around. They have seen the benefits. I think patients really like it. I think it improves access. I think the outcomes are on par, if not a little bit better sometimes. So CMS, I believe, will keep a lot of this around. It has actually expanded the scope of services that can be offered virtually. And a lot of programs focus on like the professional time that's spent in billable via telemedicine. But the real models that are going to do well with this are going to be a hybrid of that plus remote patient monitoring and chronic care management codes, which are now stackable. So from a fee-for-service perspective, you can build an RPM program and build your virtual care into those requirements for codes. And that makes it a sustainable funding model. But the payers, the commercial payers, for example, or Medicaid payers, really are interested in things that improve outcomes and reduce ED visits at the end of the day. So when they're going to be able to look at programs kind of more holistically, because if they think that they can improve access to care to somebody 24/7, that keeps a patient from showing up at the emergency department, the ROI on that is tremendous.
Low relative to an ED admit, right? Yeah.
A lot. Yeah. I mean, you can spend, let's say you spend $67 for a telemedicine visit that prevents a $10,000 ED visit. Right. They're happy with that. And for programs that for like specific populations where there's disparities, either racial disparities or income disparities or anything that is different. They're trying to see how telemedicine models can be used to try and improve some of those, and improve engagement with patients. And improve access to care in a lot of circumstances. So I think like your general telemedicine payers have been on board with, because it's cheaper than a face-to-face visit, and they've been interested in reducing their costs there. The concern from CMS and from I think the payers is a lot of fraud that might be possible. So it's easier to make a fake documentation digitally for a virtual visit than it is to say, oh, I had an excess of, you know, another 1,000 patients show up in my clinic in person, when I haven't seen that before. So there's a concern about fraud. There's a concern about just like people using it way too much. So like imagine a scenario where there's a person who's an older adult, perhaps living in the home, and their only current, you know, outlet for engagement with their community is going to see their doctor every month or every 3 months. And if you have access, they learn how to use telemedicine to talk to somebody more often, and it's
but that then, I mean, if that's the case, we need to maybe build systems to help with isolation. Now,
100%.
Their doctor all the time, but that may mean that there's a symptom of something else that we need to create for that.
Yeah. Well, we need to serve that group of people, and loneliness contributes to bad health outcomes. Vivek Murthy, former Surgeon General, wrote a book about loneliness in the country and how it contributes to bad health outcomes. So it's a problem that needs to be solved. And I'm not saying that there's any fault for the patients there, but it's a concern from the payer perspective that just volumes are going to get out of control. And we don't really have a great understanding of what that might look like if the full force was unleashed.
Right. Good. Well, I wanted to talk to you. I want to show you a slide. Let's see if I can put it up here. Hopefully I can. I'm friends with a group called Hedgeye. Can you see this chart here? So they just did a study based on some data from the Commonwealth Fund, really showing that, I mean, as sort of we've been talking about, telehealth is utilized radically differently based on the different subspecialty of health. So as we sort of talked about in the beginning, behavioral health is by far the most prevalent. I think that's sort of maybe a couple different dynamics where it's pretty easy to do a lot of behavioral health services over audiovisual, that you don't need as much interactive. You're not operating on someone, or you're not
right.
And then there's a pretty significant shortage of providers, and so there's a need out there.
Right. Yeah.
The fact that it gets fairly broad across a lot of specialties. What else do you see in this chart that is interesting?
Yeah, so a few things here. One, the scope of practice is always really important, which is what I tell people, is you have to make sure that's well defined, and you have to understand what can be done and what can't be done. And a lot of procedures and a lot of care really does need to be hands-on. So when I see the everything's going virtual in healthcare headlines that have come out this year, I'm always like, let's not say that, because you're going to scare people away, because there's always going to be a mix of in-person and virtual services, and virtual on top of in-person services. Those face-to-face things are still important.
Like orthopedics, I mean, that's probably a follow-up or something. But for the most part, you're not operating on a hip over telemedicine. But it is useful to maybe do a follow-up, or there's an incision infection, and you can look at that. There are valuable things, but it's a pretty, whatever that is, 2% or something, 1%.
Yeah, and what you're seeing here is the way that I usually break it down is things that are more behavioral, and that can be done through taking the patient history, and things that are more hands-on, or that are more just physical. Orthopedics, reimbursement's really high for face-to-face services, so they don't really have much of an incentive to do this unless it's for patient convenience. And I think in like the surgical specialties, you're going to see a lot of post-surgical follow-up. You're going to see post-surgical pain monitoring via RPM. You're going to see a lot of like sort of shorter term programs. But for behavioral health, endocrinology, rheumatology, even neurology and primary care, which you see up there, that's relationship-based long-term care. And a lot of times what you're going to see are these hybrid models that are collecting that RPM data, but also kind of staying with patients over time. So behavioral health, I have 43% from another data source. So this looks like it's pretty consistent. Of 43% of telemedicine or virtual visits this year were behavioral health oriented. And a lot of times that's talk therapy. It's so subjective, or it's just a subjective evaluation, a conversation between a psychiatrist and a patient that results in a prescription or an adjustment to a prescription, or it's a conversation with a psychotherapist for 50-minute cognitive behavioral therapy, which the studies show that doing it virtually is equally as effective as doing it in person. And so during COVID in particular, it just makes sense that that's something that naturally can shift over to this modality of just audiovisual. There is a lot of interest in that space to doing mood tracking and to doing some automated things through applications. So the hybrid model still holds water in behavioral and mental health care as well. Endocrinology, primarily diabetes, and that's where you're going to see that.
They maybe are following up, maybe they're changing the meds dosage potentially, or like talking through exercise and diet and the impact on your long-term health. What I was struck with that I want your feedback on is it looks pretty good to me. I mean, it looks to me like the uses are in specialties that I would expect would be augmenting care pretty effectively with telehealth. It doesn't look like, it's not surprising that you would see like pretty large adoption in these categories and not great adoption in other categories.
Right. Yeah, I think we're going to start seeing endocrinology is going to maintain a large percentage of this because you're monitoring blood glucose over time. We're going to see primary care start to move up there more because that model, I think, is going to be proved out in the next several years as being a really good way to do things. I think maternal health is going to pop up a little bit more for post follow-up of postpartum follow-up. I think that that's an area of tremendous opportunity to prevent postpartum mood disorders and to just stay in contact with patients because that's a very dangerous time for women after they have a child. So I think that's going to be an area of interest. I think that cardiology and hypertension management, hypertension is often managed in a primary care setting, but I think cardiology for post-op monitoring and then cardiology for some of those more intense conditions are going to be kind of moving up in the world. Congestive heart failure clinics are a well-proven model for RPM. And so I think we're going to start to see that continuing to move up quite a bit. And then the issue there,
that's an RPM space where there's a discrete set of data. I mean, weight and maybe just weight, but very few set of things can be pretty predictive in that space.
Right. Yeah, I mean, those models for preventing readmissions in congestive heart failure are really, really strong, the evidence there. And we're going to keep seeing that. For people who go to post-acute care afterwards, you're going to have a responsible clinician that's able to monitor and be proactive as opposed to them showing back up at the emergency department. So those are going to continue to grow.
Yeah. Okay, and then have you seen any data on the cost to treat? I mean, there certainly are more avenues, more ability to treat. If you try to stay in the same level of service, are we seeing cost savings?
So the way I think about this is from an economic perspective. So from a patient perspective, you save a lot of time costs for doing virtual visits, virtual care, where you don't have to spend time in traffic driving, you don't have the gas expense, you don't have waiting in the waiting room expense. So from an economic cost perspective, it is better for patients in a lot of circumstances. I remember when my mom was sick. I mean, if something went wrong, we would be in the car driving 45 minutes to Northside Hospital in Atlanta, show up there, wait, get seen, go home, and show back up the next day. It was taxing physically, but also it was a big cost and expense. For the system, I like to think of cost as return on investment. And so the actual cost of the program is fine, but if it produces value in health outcomes or prevents utilization of costly points of care, it's a good investment to make. And so I have a number here. There's not a lot of data on like costs for these programs, but RPM programs from one peer-reviewed piece of literature range from about $275 to about $275 to about $8,000 annually. Now, what has happened since the early 2000s is technology cost has come down so substantially that it's really closer to that $275 annually to run an RPM program per patient. And so if that program prevents a $10,000 stay or emergency department visit, you are generating cost savings and return on investment for the system.
You get a one-to-one. I mean, you could have, I don't know what the math is, you could have 100 patients and prevent one bad complication. Yeah.
Right. So this area still has to be borne out quite a bit. I think the goal would be for it to be no more expensive. But I'm a big fan of, and reimbursement's kind of the issue here, because you can technically, if you were to pay less for telemedicine and force everybody to do it, then sure, you can reduce cost, but it's not really sustainable to do that. So I think that the models being incorporated in a full risk type setting are probably what's going to generate the cost savings, because both the fee-for-service incentives are gone and because these modalities will allow for better care. I think what needs to happen is at scale, we'll be able to see population level cost impact of just improving the care delivery for chronic illness. And that's what I'm most interested in, reducing demand by improving health.
Yeah. Okay, excellent. All right, so let's go to a couple questions. So one question is, can we speak to the release of the physician's fee schedule and how it relates to telemedicine?
Yeah, I think we've covered this a little bit. There's been expansion of services that are allowed. So one of them, I can't remember all of them off the top of my head, is the cardiac rehab can be done virtually now. There's hospital at home that just got announced. So certain hospitalizations can actually be done at home now virtually. So what we're seeing is that expansion of services that's going to fuel adoption. So as long as reimbursement's tied to it and that reimbursement is sufficient, you'll see adoption take up. And I still think we're at parity for during COVID, during emergency use. I haven't seen the adjustments to the professional time for telemedicine reimbursements. I have to take a look at that. But RPM, for example, and which you can do audiovisual during RPM. You just have to meet the requirements for the code from CMS. RPM and CCM just got bumps and now can be bundled. And so, or stacked, I should say. And so that gives you enough funding for a pretty robust virtual care program.
That was an important change, because they always were sort of in conflict.
Yeah.
Now that they're aligned and can be stacked, it's much better.
Yeah, and there's a new code out that's called PCM. It's Principal Care Management. A little lower reimbursement, but it allows for a little bit more flexibility for clinical staff and healthcare professionals to actually do some of these services. Now, a lot of these are, were built, except for RPM. A lot of them were built for kind of phone-based consultations or like in person. But what they allow for is for programs to build them with technology in mind. And so as long as you meet those billing requirements and you document properly, the technology really facilitates the efficiency of the program. So it makes it scalable, makes patients more engaged. It's just a tool to be used for it, but those funding streams are available.
Okay, interesting. That makes me ask about some of the things I'm following are not really about a direct consumer, direct to patient telemedicine, but more oversight and sort of allowing maybe a nurse practitioner to be now overseeing, not in the same building, but over telemedicine. So you can have a much more flexible business model of how you could roll out health services.
So how we work at Avenue, which is our full service bolt-on virtual care company, is we have clinical staff from Wanderly, which is a technology marketplace for healthcare professionals. We have 52,000 clinicians on there. It's like an Uber or a kayak.com like experience. But what we're able to do at Avenue is pull from them and have them set up specific shifts. And we operate under contract to healthcare facilities and physicians. So if they want to set up a virtual care program that's nurse driven, we have the technology, we roll it out with them, and then our clinicians will do these set visits with patients, and then they have a general oversight over us. So they have full visibility in everything we do. They set the clinical program. We are in communication with them, but we're off site. So that allows for more flexibility.
Previously, you weren't allowed to be off site. You had to be like physically in the building. And that's it gets less press than the teledoc and the RPM sort of direct to the patient, but I think it might be more impactful to the long-term sort of way that health is delivered to patients. Because exactly what you can design business models that are kind of the more normal outsourced providers with the proper oversight, but it doesn't have to be physically next.
Yeah, so we were built with that in mind. So when that change happened, it really unlocked our ability to do this type of business. So we recognize that staffing is a big issue for rolling out these programs. It's hard to adjust somebody from face-to-face visits to now doing virtual care. So we don't take up office space. We operate off-site. We have our own clinical oversight, but we do operate under general supervision from a physician that's off-site and responsible for that patient. So we get really close up there. We do allow programs to roll out these types of models without having to deal with the political changes internally, upfront funding. And so it's a really flexible model. And so we don't go direct to patients. So a patient can't come access our services unless we're doing it through their existing healthcare provider.
Yeah. Yeah, so that we'll see over the next couple of years, but I think that may be a more impactful long-term effect of, I mean, that's sort of a telemedicine in the back office aspect of things. That's I think can be really powerful.
And that's exactly how we see it. And so there's obviously the direct consumer components that operate, but there's very few people in the space that are able to bring this kind of full solution. We saw the growth of this about 10 years ago with outsourced chronic care management. And that was a code that came out much sooner, but it was really inflexible and didn't have enough reimbursement. But the growth of sort of outsourced RPM and sort of these hybrid virtual care models using those codes is going to be, I think, a bigger area.
Yeah, I agree. Okay, and then this one, do you see big EHR companies, Epic, Cerner, Meditech? Obviously, they're running the hospital data, and Teladoc just integrated with Epic. I don't know if it's a question. That should perhaps help with the last mile.
Yeah.
Are you seeing Epic and Cerner playing in this space?
Yeah. So I think the EMR is an interesting area right now. They were built for billing, and they really haven't done much to alter care delivery. It's actually just mostly contributed to physician burnout.
Yeah, right.
I got into a Twitter fight, like, gosh, it must have been in April or something like that. And there was a surgeon in Colorado who was like, the EMR has done nothing but contribute to physician burnout. And I was like, no. I was like, HIT, patient safety, it's really helped with data and all that fun stuff. And I went to Google Scholar and I was looking for outcomes that are linked to EMR implementation and found nothing. I was wrong.
We find something on Cerner's website, but that's about it. So.
Yeah, and I told him, I was like, I just proved myself wrong on Twitter, and I was like, good, because now I'm not going to be saying all this stuff. They're really serving as the foundation for these models. So our platform integrates with EMRs to share data, put clinical documents in. It's really becoming sort of the central database for the patient's health information. Now, the big ones are trying to do more into kind of meeting the patient there and informing them with their data. Judy Faulkner, I think in October, was doing an interview and talked about patient uptake of MyChart, which is Epic's app to link with an EMR or your patient records. The problem is it's not built for the patient. It really, like, patients, according to Judy, they don't use it, and like 0.5% of patients have downloaded their MyChart app, and she says that they, according to her, patients don't want to manage their own health data. They want the health system to do it. I fundamentally disagree with that. Patients want to understand.
Do it with her shitty interface.
Yeah, it's really bad. It really is it's not built for the patient. It's not intuitive. It doesn't explain anything to them. And so, like, our app is built for patients to meaningfully understand their own health and to understand how they're progressing with their health. And that type of being built for the patient, adding value, is what needs to happen. And the big EMR companies, I don't think, have done a good job with it. They've made some acquisitions to be able to try and incorporate, and they will always have to be a point of integration for any company that's operating in the space. I don't think that they're much of a threat just based on their track record. They're going to have to just do acquisitions to be able to do this, because they have failed at connecting to the patients.
Yeah, I agree. They're not likely to create it internally.
Yeah.
And they're better off even partnering than really acquiring.
Yeah.
I think that with the way that data portability is shifting, I think a lot of the barriers to entry and the barriers to sort of working across platforms are quickly disappearing. So I think over time you're going to see things like built on top of them that just pull data out of whichever system my health record is in. I'm on probably like 6 different health systems. And I want to sort of be able to access that, but I don't want to have to interact with each one separately.
Right. I mean, interoperability is always a problem. I don't even like to talk about it anymore. The FHIR HL7 requirements that came out of the Office of National Coordinator are hopefully going to fix a lot of this data sharing issues. There's some companies that help because they use different like languages in the EMRs for clinical terminology. There's companies that are helping kind of solve that issue by doing translations between them so that the data it has good integrity. But they're still very much facility-driven IT systems. They're not really good at helping patients meaningfully work on their health, which is why there's a space for startups and digital health like companies to be able to be in that last mile area and to actually connect directly to the patients. And I heard a pitch the other day from a company that literally sits inside Epic and makes the clinician experience easier to interpret patient journeys and to like pull the data out. And I think you saw my post on LinkedIn. I said, why is this even a thing? I don't understand, because Epic has all the resources in the world to build a better interface for the clinicians that contributes to horrible burnout. The clinicians hate it. And they have had all the resources and opportunity in the world to do that. And why is there even a market for startup companies to come in here and try and do it better? They're integrated with them. I acknowledge that their interface is so bad that they need somebody else to do it for them. It's very counterintuitive to me.
Yeah.
I don't understand it, but and I have been trying to, but I can't.
Yeah, I don't think that. I don't think they're going to lead, put it that way. I mean, they certainly will continue to. They have a bunch of cash, and I have plenty of companies that for the right price we could sell to them. But I don't think they're really going to lead anything at all.
Right. Yeah, and I just it's been disappointing. And they have such an opportunity to try and improve healthcare that their competitive moat and contractual capture is so powerful that the health systems are kind of at their mercy at this point. And the cost to do to take everything and do a new implementation is just so high that like there's no competitive.
That's not gonna happen. I think you'll build facades on top of it. To sort of enable different functions to happen.
Yeah, it's out of control. And I know Google, if you go to Google and you go to YouTube, which is owned by Google, and you type in Google EMR, there's a video on there that they're trying to like put a skin on top of Epic. And I'm excited to see what happens with that. I don't know if the project's still going on. I don't know if they got out of healthcare because, except for barely, but if they got out of healthcare because they were terrified of all the scrutiny. But that was an interesting demo to take a look at.
Yeah, it's more of a search-based, voice-based interface, which is much
better. Voice is big too. We're going to start to see like patients talking and then that data being dictated and inserted into the EMR automatically. I saw a company that does it really well the other day, and that's going to be pretty big to be able to make this experience, because the clinicians are burning out because they're sitting in front of their computer screen all day and can't sit there and talk to patients. Documentation is what's really driving that, and being able to do it via voice will make things much easier.
Okay, so just to finish up, talk to me about the next. What's realistic in the next 1 year, and then what's realistic in say a 2 to 3 year time frame in this telehealth or virtual care setting?
Yeah. So I think there's a lot of variables that have a lot of impact. They're still up in the air. think the regulatory space is going to get interesting. But I think all things are pointing towards a large portion of care being transitioned over to some form of virtual. It's not going to happen overnight, but I think these hybrid models are going to start to gain adoption once the workflows and reimbursement stuff settles down. The changing payment environment between fee-for-service, bundled payments, and full risk models is going to drive a lot of these types of changes. I think what I'm personally like worried about to some extent is that the marketing materials, and this is part of why I wrote my next book, but the marketing materials are going to burn some practices and some organizations that implement and then things don't go well, and then it's kind of a barrier because there's so much interest in the space now. So I was trying to cut through some of the noise by looking at the clinical evidence in there. So payment is going to drive a lot of this. We don't know quite what's going to happen. I think the expectation, though, is that it's going to grow from, a small segment of healthcare into, I think, what is it, like 250 billion?
Yeah, so I mean, I was
estimate.
looking at a McKinsey report that's going from, it's like 250 today to 600 billion.
Mm-hmm.
That's an annual number. And so
Yeah.
it's significant growth, at least by McKinsey's estimations. But they're pretty data driven.
Right. Yeah. So I think I also expect that to happen. I think the new administration coming in, there's a lot of, potential increase in healthcare spending. There's a lot of potential sort of administrative things that are going to happen from the White House that will probably be favorable for telemedicine and virtual care. At the end of the day, though, let me answer your question, I guess. Let me start there. And the next year, we're going to still be dealing with COVID-19. So adoption of new clinical programs and innovation is really kind of on hold a little bit just because the facilities are really just trying to take care of COVID patients right now. So I'd say the next year is going to be focused on vaccine distribution, healing from this. There's going to be a lot of mental health innovation because of the stresses and the impact of COVID. So I think the first place we're going to start to see a blossoming and a complete shift over to virtual care is going to be mental health and behavioral health services. And I think we have seen that. I think we'll continue to see that over the next year. I think the rest of it's going to keep going at the same rate it's at right now. I think the organizations that can think about this are going to start to get things in their strategic plans. They're going to start to say, okay, 2021, we're going to move up our timeline for virtual and digital, and we're going to start putting this out there now. They were forced to do it, but now I think they're going to revisit it and be a little bit more systematic about this. And I think over the next 3 years, we're going to start to see a blurring of the lines. I talked to you about this in April, and I talk about this a lot. There's a blurring of lines between where you get healthcare from and what healthcare looks like. So it might be from an organization that's not a hospital or a physician practice, but it might be something like us, which is an add-on to that. It might be a tech company. Amazon just fully rolled out their pharmacy program. You might start to see some additional care services that come on top of those prescriptions because now you know what disease a patient has. You might start to see, the traditional health systems kind of trying to look a little bit more like a Teladoc, trying to look a little bit more like a Teladoc Livongo combined organization. And then I think by 2030,
one of the things I'm looking at in the traditional ones are with telemedicine, you can sort of increase your catchment area. Mm-hmm. And say for the cardiac practice, you might go to nationwide and treat sort of hypertension and early cardiac, but then sort of it escalates and you can fly people in as needed. So we're already doing that a little bit in neuro and cancer, but I think you could expand the practice areas that are nationwide.
I think that we're going to start to see the need for I shouldn't say lower, but different clinician credentials being utilized more than just the physician, because when you have the opportunity to see more patients and you're a really good practice and you're very competitive, then more patients are going to want to come in there. And so you're going to have to figure out a way to scale the programs. I think back to when my mom was sick, we went to MD Anderson. So it was a 2-day trip to go over there, went to go see the head of the leukemia department. And, you know, at the end of the visit, everybody was disappointed because it was like, why couldn't we just do this virtually? Like, why did we have to come here? Partially is because if we were going to get enrolled in the clinical trial, then we had to be on site, which made sense. But we left and it was like, wow, this could have been a facility telemedicine. But when you have that opportunity for facility and direct to patient, there's only so much time in a day for a physician. So that's going to be a bit of an issue when you have really strong centers of care and really strong practitioners that everybody wants to see, and they're in such demand. And then you have others that are in less demand and haven't figured this out yet. So you're going to see the ones that have not adapted to digital, that have adapted to virtual, start to lose market share, and they're going to be hired or bought by the other ones. So I think we'll see that.
Yeah, and there's definitely the different levels of licensure are needed for different interactions, right?
Yeah.
Quick follow-up, you don't need to see the head of the department.
Yeah.
But he or she is available as something changes, they can overread it or look at it. So.
Right. And so there's one other thing I want to cover before we jump off, but just in conclusion here, I think we're going to start seeing pharmacists having more of a clinical role instead of being behind the counter. We're going to see them talking to patients more and being routed. We're going to see, we have a lot of pharmacists, by the way. There's a glut of pharmacists in the market, and they're all very happy because they've been pushed behind a counter to dispense meds when they're high-level, high-trained clinicians. Yeah. So we're going to see them coming into place. They know chronic disease management. They know medications extremely well. They might start taking a lot of the medication polypharmacy patients away from the physicians. And then, we're going to see social workers coming into a virtual care team that might address socioeconomic issues, and they might do it via virtual care. So that patient might have been identified during a physician visit saying, oh, I haven't eaten in 3 days, or I have difficulty affording my meals. And then they get routed to a visit with a social worker who says, I'm going to get you set up with this program so that we're more able to effectively and holistically care for patients. I think that's what we're going to start to see. And I'm personally very excited about it. Now, the one thing I do want to talk about, and I think is really important, is there is a digital divide between urban centers and rural centers, and then certain income groups. If you look at my book, this is my plug for my book. My next book will be coming out. I cover what we know about internet access and smartphone ownership in the country. And you can see disparities. I will say overall, it looks good for virtual care delivered via smartphones. Even people who make less than $36,000 a year have a pretty high rate of smartphone ownership. And so a lot of questions come up with, like, can lower income folks use this? And the answer is many can, but that disparity for people who don't have access to broadband internet, don't have access to smartphones, will have an access challenge. And we don't want them to not have access to important healthcare services that are more effective. So we don't want a two-tiered system of healthcare. So the FCC back in early COVID and a lot of congressional bills have really been trying to push internet expansion to areas without it, and the ability for healthcare providers to provide tablets and smartphones, which many payers have been doing for a long time. So that's an issue that has to be addressed. And I do think that it is top of mind when it comes to these types of services.
As a percentage, not that many people don't have access, but we have to have that safety net or that ability to provide a tablet or a smartphone for those patients that don't have it but need it, along with broadband. From FCC or kind of somehow overlay of that.
Yeah, I think 5G is going to help a lot as that rolls out. We get more coverage expansion, get faster internet speeds. I think that's all going to happen. I think wearables are continuing to accelerate. Even this year, I've seen just some remarkable physiological monitoring wearables come out and get FDA approval. I think we're going to start to see digital therapeutics that are FDA approved. So not necessarily like a clinical program facilitator, but an actual digital therapeutic that actually the digital device itself is the prescription. I think we are going to start to see those used more, particularly in behavioral health conditions where apparently it's just more amenable to those types of changes or those types of interventions.
Yeah, we had a real success in one that was in the eye care space, but yeah, they're starting to be a couple every quarter that are true digital therapies, not a coaching app, which I wouldn't count, but something that actually replaces the pharmaceutical treatment.
Yeah, and those are very scalable. Their cost of goods sold are really cheap, so they have the potential to be really important. And I do differentiate between like apps that are used as part of a clinical program for like connecting clinicians and doing RPM, and these digital therapeutics. There's an important distinction there. We just wrote a paper that's been accepted at American Psychological Association that looked at the evidence for mental health apps that are consumer focused. So like Calm, Headspace, Sandbello, formerly Pacifica. Those apps actually have really, really positive reviews for depression, anxiety, and stress. So they clinically reduce those symptoms. But the evidence isn't quite strong enough yet to say that they are effective. But this is a gray area too. They're not FDA approved, but they have evidence and they're consumer available. And what we're also going to see over the next 4 years is the FDA has launched a digital health center of excellence. We're going to see some more regulatory action about marketing claims and trying to protect patients from things that say they can help you with your depression, but may not be able to.
Right. Okay. Well, Robert, thanks for talking about this. So talk about your book just quickly. When does your book come out? Do we have enough time to read your old book first before it comes out? What's the status?
Yeah, so it should be out in 2021. I'm submitting to my editor next week, and they'll go through copy editing. So it won't be quite ready until probably mid 2021. But I think it's going to be really impactful, and I have some good stories, some like real life examples. I talk about my experience with my mom, and then I go into the evidence really heavily. So I really do believe it's going to be a great overview of the space, and it solves a lot of like questions that are out there.
Okay. Excellent. Well, Robert, thanks for walking through this exciting time. Lots of change, but it's an exciting time. Technology.
It is. It's been quite a time, and I know it's been very stressful for a lot of people, and our frontline clinicians, particularly from our work at Wanderly, have been really spearheading this response, and they have not been getting any help from the top. And I just say that very appreciative, and I think that there's going to be a lot of change, both good and a lot of need for healing after this is over. But healthcare, I think, is looking brighter on the other side of the tunnel.
Yeah, well, it's certainly, we all have become more and more aware of how critical it is to have really world-class healthcare. And so it will continue to get better over time. And I agree, it has a bright future.
Yep. Awesome.
Okay, thanks, Robert. Appreciate you walking through it with us.
Yeah, absolutely. Thanks, Vic. Always glad to do it.